Well, good morning, everybody. We're coming into the home stretch here, and I'm very grateful to kick off our last concurrent session. We have two gentlemen that are section heads. They're going to tell us everything we need to know about being profitable and being happy and solve all of the problems of pediatric endocrinology. So with that being set up with their expectations, I'm going to introduce them very quickly for their bios and then turn the floor over to both of them. So the first up is Dr. David Sparling. Dr. Sparling is the section chief here at Oklahoma Children's. And again, I want to thank Oklahoma Children's for just the excellent job and input and creation and setting up this program. So Dr. Sparling graduated summa cum laude from the University of Oklahoma in 2001 and did his MD PhD at the University of Oklahoma Health Sciences Center. He completed his degrees in 2009 and did his pediatric residency and fellowship at New York Presbyterian at Columbia University. He then returned here to Oklahoma and is now associate professor in the section of pediatric diabetes and endocrinology here. He serves as a CMRI Paul and Ann Milburn Chair in pediatric diabetes and became the section chief for diabetes and endocrinology in 2022. He's a member of the Harold Hamm Diabetes Center here. He has interest in type 1 diabetes, and his research focuses on both the diabetes diagnosis and management in type 1. Oklahoma has been a very strong representative in terms of pediatric diabetes care. So he is an investigator in TrialNet and has ongoing basic science interest too in examining the role of adipocytes and inflammation during weight loss. Our second speaker who will be following Dr. Sparling is Dr. Paul Thornton. Dr. Thornton is head of our group at Cook Children's Medical Center. He received his degree from the University College of Dublin. You might notice he's got a slight accent. He completed his training both in Ireland as well as in the UK, and then came to the States and spent most of his career at the Children's Hospital of Philadelphia. He is well known, obviously, in the area of hyperinsulinism, both at his time in CHOP and then has a hyperinsulinism center set up at Cook Children's Center for many years that draws referrals throughout the U.S. as well as abroad. It's a center of excellence in hyperinsulinism. He has served on a number of boards, including the Pediatric Endocrine Society and the JDRF. His interests, of course, are in improving clinical care for hypoglycemic disorders. He is also, again, besides the time that he spent in hyperinsulinism, hypoglycemia, has other interests, including differences of sex development and congenital adrenal hyperplasia. He has authored many articles and textbook chapters as well, and is a presenter of research at national and international meetings. So with that, I'm going to turn the floor over to our speakers, and I'll come back and moderate at the end. Thank you.
All right, can y'all hear me? We're good? All right. I apologize if you see me look down at my watch every once in a while. It's not that I'm ignoring you, it's that I'm currently on service and my pager is my phone. Though Dr. Shaw is also currently carrying, thank you, my diabetes pager at the same time. So if you hear that go off, blame the patients. All right, so you all will learn also that I joke and pun a lot, and so the only constant change is more in reference to not changing things, but money. But anyway, there's a terrible joke to lead off the bat. So a couple of quick disclosures. I don't have any financial disclosures but I am a newbie, as you all found out. So when Dr. Trickerstad approached me about doing this talk, I pointed out to her that I'd been in the job for about 4 months. I had been to a course in Boston and was frantically learning how to do this job at the same time. So you're going to get some unique perspectives, and we're going to be discussing a little bit about how funding flows in the evolving academic medical practice landscape is occurring. And it gives you a chance to see for possible changes in your own practices or relate to changes happening to academic colleagues across the United States healthcare system in academia. So with that, some history. So the joy of an org chart is what we're going to start with. So which one is the laser? There we go. All right. So, and the laser barely shows up. All right. So how the University of Oklahoma was set up, and how lots of places have been set up traditionally, right? Is you've got the president of the university, and somewhere up above the president is the regents, and in charge at OU of the senior vice president and provost of the Health Sciences Center, the lovely campus right across town, where they're in charge of all of the deans of all of the, grad college and nursing, et cetera, et cetera. And down here is the College of Medicine dean that would oversee the department chairs, that would oversee the section chief and oversee the faculty. And inside that is where the medical practices lived, right? In this old system, or the classic system, is that the medical practice was contained within the academic system, where we were all in charge of our own revenue flows and paying attention to our patients. And at the same time, if you were hiring a nurse to help take care of patients, that nurse very oddly was technically working for the president of the university as much as they were working for us, right? So it was all within one unit. And there were contracts governing the relationships between the section and the department, the section and the hospital, a variety of things controlling how we interacted with the medical system. And that's how things were, and everybody was nice and happy for a while. But then the name of the game in academic medicine is consolidation, right? There's not a lot of new hospitals popping up, but what can hospital systems do? They can form massive conglomerates, and they need more patients, and so they need to take over outpatient practices as well. And that's what eventually was happening here over the past couple of years, where the system OU Health came into existence. The main thing that OU Health shares with the University of Oklahoma is that it has the same symbol and has the first two letters OU at the beginning. But otherwise, it's run by a board of directors. It's a 501c3 corporation, so it's a nonprofit hospital system that has a board of directors and a CEO, and there's the OU Health Physicians Board of Directors, which is a whole nother group overseeing the medical practices. There's a single physician leader that holds multiple roles, including, if you look over here, College of Medicine. So they have an academic appointment going this direction, but have all of these roles within OU Health as well. And that's what's overseeing our practices now. And so this made it interesting to be me. So this is my life these days, with the big black line down the middle, and I've got to live the life on this side under the president and vice president provost. We have a vice provost of diabetes as well, so who sometimes talks to me, and College of Medicine talks to the department, talks down the road. And then over here, we've got the board talking to a whole bunch of conglomerates of people, including a pediatrician in chief, which interestingly at our institution is not the department chair, ambulatory medicine director, inpatient medical director, talking to our medical director, Dr. George, who you all have seen wandering around. And that's why he always looks hairy, because now he has like 16 bosses as well. And we're all talking to each other, and then the poor faculty are down here, and then sadly the fellows are down there below us. So that's where we exist. And the question arises, what's going on, right? Why does this make sense? What is going on? And so I have to think simply and straightforward, right? And why are we in academic medicine? It's the tripartite mission, right? We're very interested in clinical care and research and education. Why are we at Pistola? It's that, right? And so we've got I have to think based off of images. So here I have our tripart. I always kind of imagine it as a stool, and each leg of the stool is supporting kind of the patient or ourselves or our career or et cetera, et cetera. Just as an aside really quickly, you don't know how hard it is to find a free image online of a three-legged stool. So this is actually generated by AI. So that's how scary we are in life these days. I can say, I would like a stool on a wooden floor with 3 legs, and it gave me this. So imagine that with our insulin pumps these days, but that's where we're at. So, as a leader, as I'm coming up, one of the most important things you can do is a SWOT analysis. So strengths, weaknesses, opportunities, and threats. And the strengths of this tripartite stool that we've generated here is it looks nice, right? It's been there for a while. We're pretty used to it. But there's some competition out in the world. Maybe wood isn't the smartest thing, right? OSHA probably says wood stools in the lab is a bad thing. It probably needs to be plastic or metal, all those things. There's certain opportunities to the stool, right? It's broadly applicable. We've been using it for a while. I can sit on it. I can stand on it. I can throw it through a window. I can do all of that sort of stuff. But the threat is, what if a hole opens up? Right. And the hole that opens up when we're thinking about all of these new funding flows and things is money. Right. Ken Copeland, who several of you know or have met or heard about before. Right. It was the section chief that hired me out of fellowship. Frequently would walk around saying no money, no mission. Right. And that's what this is. Right. If a hole opens up under the of no money under the clinical care or the research or the teaching, then the whole stool falls over. And sadly, when we're talking about money in medicine, right, it becomes clinic as the primary generator. And Ken's a very intelligent gentleman who was the president of PES and gave the presidential address in 2000, his presidential address in 2007, which I have the slides, which I'm shamelessly stealing. But it's because it's very interesting that in 2007, he's mentioning a lot of the things that are the themes that we're seeing these days. So first, costs of running a diabetes program. So all the way back when it was still the Lawson Wilkins PES in 2002 meeting, several prominent chairs across this U.S. met and were discussing that running of a clinic that has 3,000 to 5,000 visits a year, which is actually smaller now than the clinic at OU, generated a 400,000 to 500,000 annual net loss, right? So running the system is expensive, and we used to have that in our own control, and now that control's been removed. And if there's no money, no mission, where does that money come from, and what's been going on? Why is this kind of landscape changing? And so there's actually a surprising amount of literature on this. And so what we used to live in is what was called the collections-based model, where the department or the section or whatever lived and had contracts with the health system that provided some money, and then we were generating our own money, though some of that money was leaving because, you didn't get prior authorization for that visit, and so there's some denials pulling out. You've got endowments and school of medicine agreements and grants and all of that sort of stuff, and then you're paying out all of the things, operating expenses, salaries, et cetera. Every section chief's two least favorite words in the world, which is dean's tax, things like that we're paying out. Whereas this new system is called an aligned strategic funds flow model, where the medical system, for most of that income, is in charge. So all the cash, all the clinical stuff, all the billing, everything lives inside the health system. And therefore, all of the risk lives in the health system. And that's supposed to, quote unquote, free us up to do our jobs, right? They'll pay our admin, they'll pay our hospital agreements, they'll do all of that. It'll be a little agnostic to payer mix, and we'll come back to that in a minute. And we still have to deal with endowments and some grants and contracts and research, but all of the healthcare system takes over the almighty dollar. So this can become a problem, as you can imagine, has been going on here as a problem in the United States over the past year, right? Cleveland Clinic loses $200 million in 2022. CHLA lost $116 million. And why is that happening? There's this concept in economics known as the iron triangle, where there's three things that govern funds flow, which is cost, price, and sales. And those three things are forever and always will be linked. And if you think about it in medicine, when we enter a recession or there's inflation and all of those fun things, right, where the price of all of our supplies goes up, we can't say, oh, that appendectomy, or this clinic visit, this level 4 visit, hey, patient, you paid $100 last month, you got to pay $200 this month. We can't do that. So all we can really affect is, sadly, the sales aspect of that. And so that's what the systems are stuck with right now. And so if they can't rapidly change sales and they can't affect costs and can't affect price, the revenue source takes a hit. And what's the primary place that the revenue source flowing into a system? Well, it's the patient. And who's the person in charge of that door letting that patient in is the physician, is that right? It's the provider. So how does a healthcare system say, let's bring in more people, let's do all of these things? And how do they then incentivize providers to do this? Because remember, we no longer have control over the money. We don't have the risk and we don't have the reward. It's all in the medical system. Well, they're going to monetize the visit, or they're going to monetize what a system of looking at these patients, and it's not how many dollars, but it's how much work product you're doing. In other words, it's the joy of the almighty RVU, relative value unit. So if you, and what you can do is say, okay, providers, you're going to generate a certain amount of these RVUs, a certain amount of work provided to us, and we'll pay you based off of those, right? Instead of being paid based off of your dollars that you brought in, you're going to be paid off based off of your work product. And then you fund your providers, you can then fund the clinic. And the nice advantage to that for providers is that it becomes what's called payer agnostic, right? I saw a patient and performed a service. All the risk is now in the medical system. The medical system has to worry about billing and collections and yada, yada, yada. Now, we're all pediatricians. That's what we've always done, because the kid is the most important. But right, you talk to a lot of adult colleagues, there's still plenty of places that still have the concept of the fellows clinic or the resident clinic, and that's who sees Medicare, Medicaid. And oh, the private payers that pay more only see the attendings. And that doesn't happen lots of places in pediatrics, in part because we have Medicaid, but there's a bunch of different reasons that go into that. But the nice thing in the broad run for medical systems is that it makes payer agnostic. The doctor's just going to see the patient. Now, disadvantage we've all heard about with these RVUs, if you've heard about them before, is that it lends itself, the people that came up with these were not E&M billers, right? Evaluation management billers like we all are. And so it lends itself more to procedures. My favorite example of this is the placement of an Eversense CGM, which we haven't really talked about a lot at this meeting, but right, we think about Dexcoms, we think about Libres, but Eversense is placed right under the skin, a lot like an Suprelin and Implanon and all those fun things. If you see a patient, a work RVU generally for level 4 patients, about 1.5 work RVUs, 30 minutes of work. Eversense placement is 58 RVUs for about 15 minutes of work. So procedures rule when it comes to RVUs. And last but not least, who will watch the watchers, right? If we're deciding we're going to get paid or this work product is now this kind of arbitrary number, who comes up with that number? Who decides it, and who decides what number you get awarded, right? If it's based on a bill, who's doing the billing and all of that sort of stuff. I'm a biochemist. I'm a pretty straightforward thinker, right? So patients plus problems with the poorly functioning enzyme that is payers generates revenue to the system. If we can't affect some of these things, and those work RVUs are what we do, what's the system going to say? The only thing that you can affect is the patients, right? How many patients you're seeing. So looking back at fiscal year 22, quarter 1, admin would love everybody in this room to be doing this. If you're doing a session, which is a half day, and you're doing 2 sessions every day, you are working full time. Find me a doctor that does this, because no one does it. My wife's in private practice. She's a private practice pediatrician. She doesn't work 10 sessions a week. She works 8. So, but administration's perfect schedule is that everybody that's doing E&M billing works 42 to 44 sessions a week. And, if we look at our day where you have your AM clinic, I am kind and benevolent section chief and have awarded you an hour to eat lunch. And then giving you another 4-hour session in the afternoon. We also need to discuss the importance of sleep, work-life balance, and sleep's a big part of that. So I've given you 8 hours to sleep because you need those growth hormone spikes. And then everything else of your day is there. But when work becomes a thing, your day starts looking like this, right? Where you're at home writing notes and you're ignoring everything, and your kid wonders who you are because they haven't seen you in 3 days. So that comes into play too. And the time constraints to see these patients are real, right? If you think about what's called full-time equivalent, so the full-time job of this arbitrary section of pediatric diabetes and endocrinology here with unlabeled people, we have some APPs over here that are full-time outpatient FTE. They see patients, that's their job. Then we've got attendings that have across the course of a year, a certain percentage of their time is devoted to inpatient work. Maybe you have outpatient clinics with a variety of tribal nations, and so you've got that work to do. We're active in leadership and across the system. We want to be good citizens to the system, so we've got some of that time. And then I love this, that our system has decided that we have art, which is not art, it's academic research and teaching. And so we've got a portion of that life, right? That's not dedicated purely to residents or fellows, but to all the other teaching that we can do. And so we've got a certain amount of time that we've already got established. And we already know that there's more patients coming in, right? So this is our section, new onset type 1s, new onset type 2s, and what's called transfer of care. Thank you for taking such wonderful care when we're on divert of all of the Oklahoma patients that suddenly show up at your hospital, and you do the initial training and then you send them back to us. We track that. It's called, in our section, it's called transfer of care. So over the past several years, we've had more patients with diabetes and type 1 and type 2 at our institution. I bet you all can point to the years that COVID happened in this chart as well. But that's a research topic for another day. But right, there's always more patients. But if you're looking here at the orange dots, I'm sorry for the kind of poor show up on the screen, right? Orange dots here are the number of providers over the past decade or so, and blue is work RVUs in our section. You can see that as we add providers, we bump up the work, but we also hit steady state really, really fast, right? There's another biochemistry thing, right? Steady state. So there's not capacity, right? There's only so much space. So what can you do? All right, we're already full-time and you need to increase RVUs. Find me a medical system that says, increase your RVUs. We're so proud of all of our doctors and all these RVUs that they're producing. Because what does that mean? If you have a constraint on time and you're working the same, you've just spent less time per patient. No medical system is going to say our doctors spend less time with their patients than anybody else in the nation. But that's what they're asking. Now, is see more patients why we're in academic medicine? No, that's not what we want to hit. So we have to focus on what we do and maximize a bill for patients and RVU per patient. So one of these things that I constantly am talking to my faculty is, right, don't shortchange your expertise. A 50-year surgeon that can do an appendectomy in 15 minutes gets paid the same as that first-year resident that did an appendectomy that took 2 hours. You can see a congenital hypothyroidism patient in 15 minutes or less. But that's a level 4 visit that I'm going to let our next speaker focus on all that sort of stuff, right? But we shouldn't be shortchanging our expertise. We should be paying attention to that and billing appropriately to respond to that. And then, but with all of that, with all of this complexity, is the real question then comes with the question of our age and diabetes is, can tech save us? And let's go back to Ken. Ken predicted in 2007 that technological advances are going to pose a major threat to the doctor-patient relationship. I find that I no longer take my computer into a room, because that becomes a wall between me and my patient. I'd rather just talk to them and write my note at the end of the day. But then again, my whole day becomes notes. And new technologies could transform us into something looking like radiology, where we never need to see the patient. And just makes me think of COVID, but we'll come back to that. But then Ken also said technology, we really should embrace it at the same time, right? Telemedicine. Our section's been doing telemedicine way predating. And I know a lot of the other sections here do, way predating COVID. And we should apply research technology in such a way that it's not affecting our doctor-patient relationship. You should still see your patient and just use that tech to your best abilities and appropriately bill for it. And just trying to figure out how that is. Now, technology itself is always going to have its own issues, especially the joys of EMR, right? So a few weeks ago, our system went down. It's Fort Worth's fault. A server exploded in Fort Worth, and Meditech across the Southwest went down. Every Meditech went down. And my residents, I was on service, my residents lost it. They had never seen this, a paper note. And they're like, how do we discharge a patient? And I was like, oh, I know how to do this. Hand me a piece of paper. And they did. It was a white piece of paper. And I wrote, discharge patient, signed it, dated it, timed it, and handed it to the nurse. And they're like, what about MedRec? And I'm like, yeah, that wasn't a thing. So, right. So technology can be good and bad. Notice I have to sing a different tune here. Here's a young, naive intern holding the last paper chart of the ER and the ER that he is working. His very smart upper level and very smart attending are sad about this. And it took me till now to realize why they were so sad. Because for the next 2.5, 3 weeks in that ER, it was not a fun place to work. So, but I was so glad. But technology can help us, right? So Oklahoma was forward thinking. We were forward thinking. If you all heard about bariatric surgery, we were also very knock on wood, very forward thinking about CGMs. We did a lot of advocacy at the state and finally convinced the Medicaid system here called Sooner Care that the prior authorization requirements for a person with diabetes to get a CGM is, are you a child and do you have diabetes? Type 1 diabetes. And we're working on type 2 now. And that happened literally January 1st of 2020. So here's 95251 following up that which you generate RVUs for, that we're billing for, we can get some money for pre that. And so there's not very many patients. Post, there's a few more. I can't imagine why there wasn't a whole bunch of these in 2020. I don't know. It's just maybe we had less patients, but you can generally see the upward trend of this. So yes, it's new technology, but we're also making sure that we're billing for it. But does it really help, right? We have to do more time. We have more times to bill. We have open invoices for 365 days because this has gotten so complex, right? I had a patient that had what's a 95251 that was being rejected for over a year, and it's because the billing department filed the wrong paperwork. So again, what's called bad debt there, where that money is just sitting there and we're not getting paid. And again, that comes back to is who's watching the watchers. And that's where we have to be advocating for ourselves. That's what I'm gonna always say. So like I said, will tech save us? There's two sides of that coin: improved time, new avenues for billing, but meaningless is what I call it use. And the time to get the patient in terms of all of that tech and what we're dealing with, right? A Medtronic pacemaker is swanned into a EMR in about 15 seconds in my brother's practice, where let's talk about how long a Tandem pump these days takes to download. So when that all comes down to it, my admin will come to us and say, well, why are your staffing ratios so large, Dr. Sparling? Why can't you book more patients into your current clinic? And if my clinic people were here, they'd start groaning, because there's this thing called Lean Six Sigma where you do these flow charts to look how patients flow. So here, every 3 to 5 times in my clinic, every 30 minutes, somebody gets checked in, vitals and all that sort of stuff. Technology goes somewhere. We have pediatric nurse specialists and CDCESs and the providers. And we have our behavioral health specialists because maybe somebody just scored a 12 on their PHQ-9 and all of that sort of stuff. And the nurse is taking care of meds. And then, okay, every 30 minutes, that patient's out the door and schedule. And oh, by the way, we also have diabetes phone calls coming in and endocrine phone calls coming in. And all these things have to be triaged, and who goes to the right person, the provider, diabetes educator, nurse, or the on-call MD. And oh, at the same time, we've got to do growth hormone stimulation tests and tech visits and education visits. And oh, and all, by the way, we still have tech scheduling and all the referrals flowing in and telemed happening at the same time. And then the crazy hospital doctor at the time is also saying, hey, we need to work this patient in tomorrow, right? And that's all going in, let alone all of the other refills where the state site for newborn screening, for thyroid and CAH, calibrations for equipment, stock, everything. It just gets nuts. And so I say, when it comes to this revenue cycle, when it comes to all of this complexity, when it comes to how do we see more patients, generate more revenue, what's going to save us? And I'm going to say it's people, shockingly. But what it all comes down to is what the people around us and how we can handle it, right? So patients love to be seen. Last year, I ran these numbers last week. We had over 10,000 patient encounters in our clinic. We had and inpatient. We had over 24,000 phone calls that came to our clinic. We had greater than 20,000 individual labs, not counting bone ages, into our clinic from our clinic. And that's all got to get handled by a bunch of amazing people. There's certain things that we can do, right, to help maybe decrease that load of people. We can do telehealth, which can decrease the people involved as long as it's reimbursed correctly. And we can talk about that in a second, right? So this is starting in January of 2020 to today. Oh, look, there's COVID, right? Hitting our trend by appointment type. So this is all total appointments per, I think, month or week. I can't remember, week. And the orange line here is our telemedicine visits. So look, we instantly, because we've been used to doing telemedicine, turned on telemedicine. And so all of our visits practically became telemed. And then we've maintained a pretty steady state because Oklahoma, again, forward thinking, said telemedicine visits have to be reimbursed at the same level, right? Just because it's telemedicine doesn't mean for a 95251 or a 99214, all these fun RVU things that we'll talk about in a minute, they're all going to get reimbursed the same. So we've maintained that so that we can decrease the load on our clinic and help all of those people. Now, We can also I can really point out that increasing the people around can increase productivity. First of all, you have proper handling of patient needs. You don't want to become the world's most expensive administrative assistant filing a prior authorization. Let somebody else file that prior authorization so that you can go see a patient, because that's important. You can work those urgent patients in, which generate more revenue. And then you can have certain things like, more and more clinics in pediatric endocrinology are becoming what's called 340B clinics, like ONC clinics, where the system operates like CVS Caremark. But instead of CVS Caremark taking profit, the system, in terms of its pharmaceutical management, reinvests. And what do I constantly advocate for? Reinvesting in people to do the jobs, because that's what's important. And you have to have then, therefore, regular discussions about system support. So our leader is a surgeon. The frequently at which I've described our CDCESs as OR nurses has borne fruit, because they've never thought of it. They just thought that the CDCS nurses were doing vitals. I'm like, no. I can't do my job without these people, just like you can't do your job without an OR nurse. And they're like, oh, well, it makes sense. And they granted us some new CDCESs. So then the question becomes, what are the standards? Like how many MAs, how many PSRs do you need? My wife's clinic, I think, is perfect. There's 2 doctors. There's a biller. There's 2 nurses that are PICU trained. So that small town Oklahoma does not know that how good they have it with 2 board certified pediatricians and 2 PICU nurses running the clinic. How many LPNs do you need for clinic nursing? How many CDCES and PENs, right? And part of being on the practice management committee that we're currently doing is really trying to establish what healthy practices look like so that we can continue to advocate for that. And then providers wise, are we keeping up, right? There's, to be very blunt, there's less fellows in the pipeline. And as APP is the answer, I'll always say we have to be very cautious about that, right? Radiology said, yes, nurse anesthetists are the answer about 20 years ago, and that's not going so well for them. So we have to be cautious, but APPs are absolutely a vital part to the functioning of any clinic. So again, where can we get more money? We have to generate more RVUs. That'll be talked more about next, and more patients. 340B. Right. So this concept of recouping money from certain types of prescriptions and aggressively expanding for that. What does that take? That takes people knowledgeable on how to make that happen. So having money flow in through that system is very, very important. Advocacy becomes a big thing. What is the number one medicine that 340B is not being paid for, and there's federal lawsuits about? It's insulin. So 340B growth hormone will get paid for under 340B, but insulin won't yet. That may change. We're hoping. Contracts, right? We can bring in more money. So bundled care. We have a contract with the state of Oklahoma to say we provide what's called persons with diabetes intensive care management. In other words, we get paid $200,000 a year because we show the state of Oklahoma that we block about 200 to 400 at least admissions a year by answering the phone at night, which is non-reimbursed. So, and $200,000 isn't all the money, but it's some of the money to show that we're doing good work, but we have to show them that that's important. So there's a lot of advocacy that goes into that. And where does that responsibility lie? There we go. You're right. We have to continue to remember that, yes, the healthcare system is taking on all of that, but we're part of this, and we can have an ongoing role in supporting all of those things coming in. So the clinical care really truly, those are new words, support the research and the education side. And as long as the system's doing its work and we're doing our work to help support the system in a reasonable way. And again, system doing its work is not just money, it's also providing the people for us to do the money. We can then continue to also help in with endowments, with chairs, with grants and contracts and the like. Because why do we do this in academia, right? It's the 2 other legs too, right? Education. Now with residents, they're getting less face time with the increasing complexity. We need to focus on that. We have less applicants, and we need to continue to do what we can for that level of advocacy, which is establishing personal connections through things like camp. So Camp Blue Hawk here, Camp Sweeney, of course, all of those. We have to continue to advocate to get more fellows and residents in through research for sure, right? Step 1 is now pass fail. So how are people making themselves look different from other medical students? It's going to be through research. So making those connections are going to be important, and money is going to have to support all of that. And then all of that teaching is important. And again, back to Ken, right? We need to continue to teach our trainees, not only to ask why, but really, I love this part, to be fearless in learning and applying new technology for clinical care and research. And last but not least, to incorporate advocacy. And advocacy isn't just talking to the state. Advocacy is also for ourselves, to payers, to everybody that's out there, to really to make sure that we're reasonably compensated for the work that we're doing. And that also then supports research, right? New drugs, new tech. We've got all of the amazing QI growth that's happening, like type 1 diabetes exchange and the like. But again, all of that money supporting this, and we have to be careful that that doesn't take away from time along with the increased publication requirements. I love pointing out that what a science article looked like 20 years ago versus a science article last week, and how many things are in that, right? There's like 14 supplemental figures, A through J now. But science figured that out already, and we need to figure that out on this side. How do you generate that? You don't generate that on your own. You don't have single author science papers anymore. You have papers that have 20, 30 people on them. In other words, having people there for science is the exact same as having people there for education, all of our great educators, and for the clinic. So the real end is this, right? Is teamwork makes the dream work. The great thing about the way our section's set up is that every single individual in the section is doing something different. And we all support each other. And we have an amazing team that's behind that. And so with that, I'm going to thank our ridiculously amazing team at OU, right? So here's the clinical side of life. So here are the providers. Here is our clinical direct staff, front of house. Here's our CDCESs and all of them, back of house. Research nurse, all of our amazing research and education teams, our admin people too, right? Thank God for them. And I also then need to thank, right, most important people when it all comes down to this is your family, because we don't live to work. So yes, I go to Disney a lot. Everybody heard about that last night. A lot of this is constantly run through my amazing wife, who's a pediatrician and also has a master in public health. And it's amazing that when I come up with crazy things like this talk, she generally agrees with them. So I'm very thankful for their help and understanding of why I did not go to my niece's Annie Jr. last night. So with that, I'm happy to take any questions. Or are we going to hold questions till the end?
Let's hold questions till the end, and we'll have Dr. Thornton do his part, and then we'll gang up on you.
All right, deal. Sounds like a plan. Thank you all for coming to Oklahoma, braving the wreck and all of that sort of stuff. And I will see if I can pull up Dr. Thornton.